Good morning to those that are in the western side. Good afternoon for those that we are in the same zone, and those colleagues that are in the east. Very good evening to all of you. We appreciate you for joining in these sessions that we host regularly. I must say I'm excited to be back here after a while and looking forward to today's session. My name is Anafi Mataka. I am from the African Society for Laboratory Medicine, and welcome to our sub-community of practice on DNO, which is part of our series that runs under the flagship Laboratory System Strengthening Community of Practice. Today, we are having a very interesting discussion where we talk about the introduction of the WHO standard for universal access to tuberculosis diagnostics. This is a key important discussion that we have, as evidenced by the number of people that have already joined. I can feel excited right now that there are over 118 people that are connected as we are about to start. This will be a 1 hour long session made up of an initial presentation, followed by a question and answer segment. We encourage you to keep your questions and comments coming through the chat, and we should be able to address as many of those that we can during the Q&A. A kind reminder that there is French and English and Portuguese simultaneous language interpretation. We encourage you to choose the language of your choice. Please do not remain on the original channel. To begin, just sharing a few remarks around this very important topic. As we all know, around April this year, the WHO, the World Health Organization, released its first ever standard on universal access to TB diagnostics. Just like any other diagnostics, many of our populations do lack access to diagnostics. With TB itself, as you saw from the flyer, only about 38% receive the innovative WHO-recommended rapid diagnostics, which have been proven to be cost-effective, quite accurate, and are able to assist all of us to get timely treatment and, most importantly, impact patient outcomes and global health security as a goal. So this will be a key important topic that we will discuss today. I don't want to preempt much of that. And we are hosting this in collaboration with the Global Laboratory Initiative, GLI. And before I introduce the speaker, allow me to speak a little bit about the GLI, and I will share my slide quickly. All right, yeah. So the GLI, as you have seen at a glance, is a Global Laboratory Initiative. It is one of those 7 working groups under the Stop TB Partnership, and is the secretariat of the Global TB Program. The core group itself is 15 representative constituents of stakeholders and institutions in the global and country level. And it serves as an independent technical advisory group to the WHO, the Stop TB Partnership, as well as funding agencies and countries. Its mission is to serve as a collaborative platform for the development and uptake of practical tools, such as those that we will also kind of showcase today, as well as building and sustainable high-quality laboratory diagnostics. Some of its activities include implementation of the WHO policies and guidances on TB system strengthening, as well as health systems solution at large. For those that need to get more information on the GLI, you can scan the QR code on your screen right now. We shall share also towards the end of the session, and also the link, we are going to put this in the chat. And to take us through today, on the topic of interest today is Dr. Nazil Ismail, who is a team leader for prevention, diagnostics, treatment, care, and the innovation unit under the Global Tuberculosis Program at the World Health Organization based in Geneva. Colleagues, allow me to hand over to Dr. Ismail to take us through the presentation today. Over to you, Dr. Ismail.
Nafi, and great to be here with you all, and excited to share some of these updates with you. Great, thanks a lot, and thank you very much. So as Nafi has highlighted, the topic is about this new standard that was issued in April. And just a brief few background points. I think for the audience here today, I'm sure we can appreciate the importance of diagnostics. There's an interesting editorial that was published fairly recently by Madhu Pai and colleagues, where they said if we cannot find TB, we cannot treat TB. And if we cannot treat TB, we cannot end TB. And diagnostics as such plays this critical role in being able to identify individuals with TB. We know that the clinical features are not distinct enough, at least at the earlier stages, and the use of rapid tools are quite important. Second, just not detecting TB, but also drug resistance is critical. We know we have all these new treatments, particularly for drug resistance. But if we do miss rifampicin resistance, we basically not only disadvantage patients, but essentially do not offer them what is really effective and best for them, particularly with the BPL regimens that have been recommended. What's striking with TB and the emergence is that while we do have many of these new tools recommended for diagnosing TB, the scale-up has been really limited. Some countries have done a great job, but many countries still fall far behind. And with the COVID-19, I think we've seen fallbacks, but there has been a huge amount of effort towards catch up. But beyond just the numbers, I think what's important to appreciate from the COVID-19 pandemic is the lessons that we can learn in what can truly be achieved. We know that in just like under a year, I think the testing for COVID, a totally new disease, was astronomical across the globe, right? And I think billions of tests for COVID have been conducted to this day. So where are we with TB? So this is from the Global TB Report 2022 with data from 2021. And essentially what you see on the screen is basically the cascade that follows. So the first line speaks about the portion of or percentage of people estimated with TB disease who were notified. And each step that you see here is sort of a fall off at each level. So only 6 out of 10 people with a TB disease are notified, so leaving a huge gap. And even among those that were notified, and this is what we'll be speaking about today, only 38% of people accessed or were tested with a WHO recommended rapid diagnostic test, which is really the lowest of all these parameters. And even among those that were notified, those that were bacteriologically confirmed was only 63%, meaning that over 30% of people who are usually clinically diagnosed. And I've already highlighted the limitations there. And among those that are bacteriologically confirmed, only 70% had a test for rifampicin resistance. We know the very close relationship between the rapid diagnostics and TB bacteriological confirmation and drug resistance detection. And the cascade goes on, not beyond rifampicin resistance. We know that only among all rifampicin resistant TB patients, only half of them, or just under half, had a fluoroquinolone test. And among these people, the testing for bedaquiline and linezolid is very far behind. So we have massive diagnostic gaps all along the cascade. And really what this initiative was aiming at is to close these gaps and address the fundamental issues and be more strategic and focused on how we do that. What you see on the graph on the left is two lines. The black line indicates the proportion of notified cases over a year-on-year that were tested with a rapid diagnostic. And you can see it is increasing, no doubt, but that trajectory is fairly slow. And at that rate, we will not reach the target that was set for 2025, that all people should be tested by 2025 with a rapid diagnostic. What you also see in the green line is the number of diagnostic sites in the country that do TB testing, and the proportion of those that have access to a WHO recommended rapid diagnostic. And it's obviously the lines do track, so it does indicate that the better access you have, the better we perform on that target. But irrespective, we fall far behind. So access seems to be a fundamental issue, particularly in low and low middle income countries. And linked to all of this is not just access to the diagnostics, but being able to ensure that we have drug resistance detected, that there's timely reporting of results, which are critical from a patient perspective, and obviously assuring that the quality is there when we do the testing. On the positive dimension, while we're very familiar with expert, we now have many recommendations that have evaluated other diagnostic tools beyond experts, so including the TrueNet assays, LoopAmp that was recommended many years ago, and the series of moderate complexity assays. So we have many new tools that are recommended and sort of have a healthy competitive space that's emerging. But irrespective, we still have these gaps, and a lot more needs to be done, and really sort of the underpinnings of why the standard was developed. So what's the objective of the standard? The key focus is really to improve access, and we'll go through this approach that we've taken to measure and drive access issues. The second is to improve bacteriologically confirmed diagnoses and a detection of drug resistance, which are key to effective care for patients and reducing the time to diagnosis. So this document is available online. So the link is on the slide below, and the slide will be shared. And we've also put out an editorial in the BMJ Global Health Journal. So what underpinned the access standard for diagnostics? We had 7 principles that we put down based on a broad consultation. Starting off with obviously the political and financial commitments. I think we can't move anywhere without that. But moving on, equity was quite important and quite brought in quite early. And equity across all dimensions, including public and private as well. And when we talk of equity with TB diagnostics, it's not, it's actually more simple than high-risk groups, right? It's even just any person with presumptive TB that we don't even have equity reach all people with presumptive TB, let alone high-risk groups. The second, the fundamental need for the use of accurate and rapid tests to diagnose TB. The diagnostic approach should be patient-centered. Coverage should be across all levels of the health system, reaching all sectors, including the non-NTP sector, which is the NGOs and private sector as well. The issue of timeliness and the balance between on-site versus sample referral, but making sure that the focus is not about where the testing gets done, but the timeliness of results that get back. And then the last aspect is about optimal utilization of capacity. So not just having the capacity, but using that capacity effectively, including the considerations for multi-disease testing as well. So these were the principles that were sort of derived from a broad consultation. So moving into the standard, we've set the standard against the cascade of care framework, which is more, I think, much more understandable and more pragmatic in application. We focus purely on diagnostics and access to diagnostics. There could be many other foci, but this is really driven around access. It involves a very broad consultative process with specific private sector considerations. And we did something in addition. So you'll see on the graph on the right-hand side, like I mentioned, we've taken a cascade approach to step 1 to 4, but have set benchmarks within the standard. But we've also done some work beyond just setting benchmarks, but also identifying barriers and enablers to access of diagnostics, and then did some country case studies and some more basic investment scenarios to inform scale up. So going into the standard has 12 benchmarks across 4 steps. And these are really operational measures. So each one obviously operates at a different level usually. So if you look at the step one, it's about identifying presumptive TB. The second is accessing testing. The third is a person being tested. And the fourth is a person receiving a diagnosis. So following a classical pathway of how care should be driven. But as I mentioned, these are operational measures. So you'll find that some of the measurements might quantify at the district level, some quantify within the laboratory, some quantify at the health facility, and some quantify at an individual level. And what this really highlights is that when you're looking at access and care for diagnostics, it obviously spans the spectrum of health. And we need to factor all these different dimensions and not just take an instrument focus or just a patient focus, but we need to have the entire system. And that really comprises all those elements. So moving on to the first step, identifying presumptive TB. I won't go into the details in the document, but just to highlight that within this step, we have two benchmarks. One focuses on screening of high-risk groups. And we know that high-risk groups are those that are highest risk for developing TB. It includes people living with HIV in household contacts, but other risk groups as well. And we closely want to monitor that. The second is around the use of chest X-ray for screening. While we do use symptom screen and it's the simplest and easiest to deploy, but we know the limitations of symptom screening was just only about half of prevalent TB being detected with symptoms alone. And therefore, X-ray is an important additional tool for screening. And now this becomes a key focus for step one as well. Trying to ensure, and you'll see the benchmark 2 focuses on a district level. So making sure that every district uses chest X-rays for TB screening. So not as a diagnostic tool, but as a screening tool. So just understand that difference. So the structure of these slides are very much the same about the step, the key considerations, and the benchmarks on the right. You'll notice on the bottom left is while the standard is focused on the public sector primarily, we do have of the 12 standards, we have specific considerations for the private sector, where quantification within the private sector is needed as appropriate. In terms of step one, the focus here would be obviously on healthcare workers and minors, and quantifying the access of those groups to screening procedures as routine care. Moving on, so as I indicated, we've taken a major effort towards not just setting this benchmark, but also there is a systematic review to identify enablers. So how do we address identifying presumptive TB? What are the things that have worked or not? And essentially, you'll see the same structure in the subsequent slides. But the few things come out from the review. I think, at least in terms of identifying people, it's sometimes just engaging individuals, engaging patients in a very constructive manner and a caring manner. All right, so I think we need to remember, although we're looking at the health system, the basic unit is really the patient, and they use a concept of consumer, which really reflects that it's a client service that we need to provide. I think the other thing you can read through this, but really speaks about testing people where they live, trying to reach further and further closer to communities, providing basic education, right, and community-based education if we really want to drive case detection for TB. So really creating awareness, etc. And then the use of obviously chest X-ray and active case finding strategies in communities are all found to be sort of important in addressing the gaps of access at step one. Moving on to step two, so accessing testing. So once we've done the effort of identifying people with TB, making sure that they can access tests. The first thing that we identified is a more basic one. It's just simply an algorithm in a country and may not be well or equally applied, right? So that becomes the first step, and you'll see the benchmark there is quite explicit about every health facility having an algorithm that defines the use of WRD as an initial diagnostic test, so not following on smear microscopy. And it should have some flow diagram that includes children, people living with HIV, and mention of the LFLM and EPTB. So really a sort of a more grassroots kind of health facility focus. And then moving on, I think what's also clear around access is that 80% of individuals with TB symptoms prevent at the primary healthcare level, or even lower sometimes. But largely, this is where they enter. But unfortunately, diagnostic tools or diagnostic access is sometimes limited to higher levels of care. And therefore, a major focus for benchmark 4 is quantifying and monitoring the progress towards primary healthcare facilities having access to these tools. And just to be clear, we're not saying that it should be on site necessarily, but what is appropriate based on the turnaround time. It could be on site or through sample referral. The next issue is, in terms of not just having the facility having access to the tool, but making sure that people are actually tested. So this is going to the individual rather than just health facilities with access. And this is the classical indicator we've mentioned at the beginning, about 38% of people. But you can see the trajectory is fairly low, and really monitoring that as part of the continuum that we have been doing over many years. And the last thing around accessing testing is making sure that there is within the country testing capacity. And not just the testing capacity for the day, but to meet demands across the year. That includes not just the instruments, but cartridges, etc. So only 25% of TB diagnostics sites at a global median actually have access to these tools at a TB laboratory. So we still have largely major access to smear, but minimal access to rapid diagnostics. So addressing that in terms of the systematic review, I think what's clear and kind of obvious is that, ensuring that they have better access at peripheral health facilities is important. I think the use of sample referral networks and sample transport systems and network improvements have been shown to be quite powerful in being able to improve access, and that should be a key focus. Implementing multi-disease testing strategies have also been found to be important. And I think with COVID, we've seen that obviously, I think a more equitable approach to dealing with multi-disease testing is needed, but for sure, multi-disease testing is clearly a great way. I think what also emerged from literature is around the use of social enterprise models, testing within the private sector, and there's a variety of models that we cover in the document that could be considered. And then obviously, in terms of accessing testing within the plan, we should, always consider marginalized populations to minimize access loss. Moving on to step 3. So, after identifying presumptive, making sure that there is a measurement and we can quantify and see where access is. Do the individuals actually get tested? And here, there's a few things that move further. So we've seen that while there's a good scale up in many countries with, for example, expert, instrument failures are really a major issue. And if you just forget instrument failures, sort of the preventative part is identifying problems with maintenance. And if you just look at instrument targets for error rates, which provides a proxy for impending problems, right? The error rate, we've set a target for that. It's more generous than the GLI target. But even using the more generous target, 3 of 10 countries that had data published actually met the target. So I think we have major issues in focusing on functionality and maintenance. The second issue is not just about the indicator of notifications, but also just presumptive. We need to quantify that better and quantify the move away from smear microscopy. And then the last on being tested is really addressing the issue of universal DST. So it's not just about being tested, but being tested with drug resistance as the continuum of the pathway. So that's also being part of the quantification. In this component as well, we've added a component on the private sector, and we'd like to measure universal DST practices even in the private sector. I forgot to mention on the previous one on step 2 as well, we've on the economic models, you'll see here access to testing. We've put in a standard benchmark for private sector models, and really we've quantified it at a district level to ensure every district has a private sector engagement model, whether it is through an intermediary agency or through a private laboratory engagement model. but the private sector should be using the WHO recommended rapid diagnostics for people within that sector as well. Obviously, we appreciate in some countries the private sector might not contribute largely, but in many countries it does contribute significantly. And this becomes very relevant where that is a major issue. Right. In terms of step 3, in terms of being tested, the review identified, so one thing is addressing patient-sided factors, but then also addressing clinicians, making sure there's education, but also engaging them to appreciate the importance and value of these technologies. It's not like smear microscopy. What you get out of it and its accuracy needs to be better understood. And I think also longitudinal training came out quite clearly about not just building the training course for clinicians, but monitoring over time, and also looking at issues around iterative redesign and quality improvement cycles that really make a difference in terms of the total care reaching a patient and doctors that make the appropriate request. And then obviously dealing with issues around maintenance, etc. So moving on to the last step, this step is on receiving a diagnosis. So once you've passed step 1, identifying people, the step 2, making sure that they either test with a rapid diagnostic available, making sure the person that arrives at the door does get tested. And once they leave, they need to obviously, or at that same point, they need to leave with a diagnosis, right? And here we've changed that slightly. While technically all patients should receive a diagnosis, we've honed in on pulmonary TB cases. And these really should largely be bacteriologically confirmed and also contribute to a large part of transmission. So we have a specific measurement to break down the current notifications looking at pulmonary TB with a WHO recommended rapid diagnostic to really drill on that specific issue. The last 2 things, and are quite important. The one around utilizing test positivity rates more appropriately to target interventions and optimize delivery. So we see with COVID, the positivity rates were closely tracked and gave a reasonable idea of what was going on. And this could definitely be done for TB and sort of optimize the way we deliver services and improve case finding. So we've set a benchmark on that. And the last one, but not the least and quite an important one, is setting the benchmark on turnaround time. And we set a benchmark based on hours, but also the proportion as a total of all samples received. So sort of accounting for weekends and other things. And these benchmarks have been sort of drafted to be measurable with some effort, but more easily amenable to current practice. But really ensure that we can monitor and it's more transparent and there's greater coordination between funders, implementers, and communities in making sure that access delivers not just the technology, but the services and the results, etc., that go as a package. And we've also specified something for the private sector around disaggregation of bacteriologically confirmed within the private sector. We know that a lot of clinically diagnosed often happens in the private sector, often because of lack of access to technologies. And in terms of the systematic review, I think this what they identified was a lot about use of mHealth kind of technologies, electronic systems, and the importance about linkage to care, which is obviously something that we haven't focused on in the diagnostic cascade, and then looking at financial strategies in addition. So moving on briefly to the second part of my presentation, which I won't spend too much time on, but want to just point out a few things. So what I presented was the benchmarks and sort of the bar charts that you see in front. But as I indicated, these were complemented by solutions mapping, which I've sort of summarized just now, and also some case studies, which I'll talk to right now. Just bear in mind that we do have guidelines, we have operational handbooks, and the standard sort of follows that to say this is what WHO recommended, this is how you go about doing it, and this is how we would like to measure and optimize delivery. So moving on to the systematic review on barriers and enablers, I won't read all of this to you. It's in the report, and the full report's available as well. A really good source of information. But what was very clear is that, it needs to be multi-component. So not just dealing with one piece, just equipment or maintenance, or dealing with turnaround time. It's in the entire package, and that's why this cascade of care became quite an important utility. Longitudinal nature of monitoring progress is quite critical, and therefore this baseline and monitoring becomes quite important. And then the importance of diagnostic networks cannot be oversized enough as well. Recognizing that the current technologies may not be ideal for near point of care or point of care, but in the coming few years, we do see these technologies definitely coming forward to help facilitate some of the bigger access gaps. So looking at what was very fascinating, we had broad consultation, a virtual consultation with countries, NTPs, implementers, and really did a sort of a qualitative synthesis of discussions around what was done and what things helped, etc. And something as basic as power came up quite commonly, and the power of using solar panels, right? And I think funders are now more open to such things to be included in the package of requests as well. The second was the issue of market diversification. This was really a strong point that came out from the discussions. From WHO, we've heard that, as you can see, we have 7 different manufacturers now recommended. The WHO pre-qualification process has been initiated. And really, we see market diversification being an important driver, not really only on price, but also of service levels, and making sure that stockouts and other things, there is sort of a plan B always for countries. Refresher trainings and incentives. I think the incentives that were identified in Nigeria are quite fascinating in how they've sort of improved service levels. But I mean, even post-COVID, I think a lot of the lessons learned were around video-based refresher training. The world has changed, and I think we need to become more attuned to where we are now. And then what was also very strong was around the private sector engagement, so working between them. We know with COVID, I mean, the capacity in public sector was really infinitesimally small to be able to fully deal with the pandemic, and drove a lot of partnerships. And I think we should leverage these partnerships now for TB as well. And it could be models where samples are sent to public sector at cost, or traded cost, or providing discounted prices to the private sector with engagement and sharing of data models. And then just to finish up the last 2 things, from the country case studies, I think we had 2. One was the Nigerian case study. I think that the picture on the right tells 1,000 words. I mean, what I found very critical and important that they highlighted was they viewed it as a package. So they didn't just see the instrument, right? So when they deploy the technology, they don't just deploy the technology. It includes a package with a solar panel. It includes an SOP that's stuck on the instrument because staff rotate quite a lot. It includes training, but community engagement. So there's a whole package that goes in delivery when they start off a new site. And for me, that was really a very useful way of scaling. The second was the Philippines case study. I think a lot of people have seen this in terms of the diagnostic network and the striders. But what was most fascinating for us to learn was, this mechanism was initially for TB, broadened to include the collection of samples for other diseases, and they've extended it now to even include delivery of medicines, right? So it really just shows you the importance of networks. We know Coca-Cola can deliver a Coke anywhere in a country usually, and we should be able to deliver health services anywhere in a country as well. And then lastly, on the cost issues, so often that's perceived to be the major barrier, and it is a reality for many low-income countries. But I think there's a few important points to highlight. The one is there's been a good diagnostics review in Lancet that compared different diseases and looked at the cost and not just the effectiveness, but actually the benefit, right? And it was TB came out tops, right? So the investments you make for TB really have a massive return. Because I mean it's a treatable disease, right? So you actually cure people, and there's clear benefit in investing in TB. The second is in terms of volumes. I think we undertest, and With HIV, we've seen price drops quite significantly. We started seeing it now since, with the TrueNet pricing coming down. We do think with the other competitors that are sort of on the landscape horizon, prices will come down, but we really need to drive the market to drive pricing. And we really need to uptake these technologies as COVID has done. The third is, I think COVID has taught us what is a quantity, right? There's been billions of COVID PCRs. It's quite shocking. And for us at TB, we really undertest. And I think this needs to be clear with funders as well. And we need to put more money behind this. And then lastly, I think when you're looking at, the cost of diagnostics often comes up as a big budget piece, but when you look at the total health cost, it's actually relatively small when you do the sums, right? So it's like 3% on annual spend or less than 0.15 of total health spending. So we're not asking for a lot, right? In terms of making a difference. And I think we should make these cases with our NTPs and not our NTPs, but actually treasuries within countries. So in summary, I think the standard really aims to make sure that everyone gets an accurate and rapid diagnostic. We improve our bacteriological confirmation. It's really about us taking on the standard and reaching universal DST. So these are the endpoints that we'd like to see. This upfront investment will definitely accelerate health coverage, ensure better health for all. And we know that it saves lives. I mean, effective diagnosis and treatment does save lives. But what's important, and I think this audience, but also the broader audiences as well, that we really need to have participation from all role players, including all those in the core, but implementers, funders, civil society, private sector. And it's really about putting hands together to learning from COVID and really taking a major leap forward with the diagnosis of TB. Thank you very much.
Thank you very much, Dr. Ismail, for the wonderful presentation, quite loaded with a lot of very important information. I just liked the fact that you also went ahead and even showed how the return on investment for TB diagnostics is very critical. So colleagues, it's time where we take questions and comments from the chat. Please keep them coming through. I have seen already some of them coming through, some of the exchanges between Margarita and colleagues already there. So maybe our starting point would be where she mentions the inclusion of the private sector. Many of the times, we always work most of the time in the public sector, and we forget the private sector. But before maybe you take that, I think what we feel we want to get out of these discussions is we now have the standards. I'm hoping the people on this session could actually share their honest opinions. Have we covered all the things that need to be measured? And most importantly, are we able to measure this, and what are the sources of information for measuring this? To pick one example, if we're talking about turnaround time, are we honestly able to measure that within our settings, at least at a national scale? So maybe let's begin about the perspectives of the private sector. Dr. Nazil, as you worked through these standards, what had you in mind? Did you feel like you had covered them?
Yeah, so I think, as we've had a broad consultation, and this is sort of not just within Africa, but Asia, South America, I mean, all the low middle income countries were largely consulted. And it's very clear that in certain parts of the world, I mean, like India, Nigeria, I think even Kenya, the private sector contributes largely to the health services, right? And we cannot ignore it. Some countries, maybe it's not as big, but in countries where I think these 10% of your notifications come from the private sector, it's definitely an issue that needs to be tackled well. I think we need to make sure, I mean, these are the same patients, right? They collect some little bit of money, they can reach a health service in the private sector and they pay for the service, right? But then they get smear microscopy. And we need to make sure that we build models to serve people. And therefore, what we put in the standard is making sure that every district in every country, where this is relevant, obviously, does have a access model. So, if, for example, I think in India, they initially trialed out the IPAC TB kind of model, in terms of making sure that the private sector could access the concessional pricing in these specific countries, but they would share data back with the NTP, and in return for low pricing, but they would guarantee that the patient does not pay a premium. They pay a capitated cost of a test. But then these other models, I mean, there's some countries that have moved to say, look, you know what, you discuss with GPs and you say, look, you can send it to the public sector. The patient doesn't pay anything for it, but all GPs would have access to, for example, the molecular rapid diagnostic. So I think there's definitely models, and we have sort of highlighted these, and there are references in the document. So we encourage countries to really look at that relevant section, see what the benchmark is, and really uptake that specific one.
Great. That's very important and also I'm glad to hear that so many of those considerations have been taken into account. As questions keep coming through, there's one that just popped here just to make sure that we are all on the same page. Somebody has asked, I think it's actually Kiati Dave, who is asking if the about TB LAM data is available and included in this TB diagnostics. Maybe to broaden that, to just make sure that as we go on with the discussions, we are all on the same page. What are these rapid molecular diagnostics? Maybe you can just...
I should have. I should have started off with that, right? So I think in terms of what we refer to as a WHO recommended rapid diagnostic, it includes diagnostic technologies, largely molecular tests that we now recommend for TB. The classical one is Expert, but we know that TrueNet has come on board, TB LAMP has come on board. These are all molecular tests that do TB detection accurately and fast, but also includes the larger platforms that are used for HIV. So this includes Abbott, Roche with the BDMAX, which is not so much used for HIV, but more for AMR and COVID, and the Heinz system. So we actually recommend all of these technologies. You could use any one of them, but these are what we'd recommend. But coming to, the definition of a WHO recommended rapid diagnostic includes LF-LAM. However, for this standard, because we're addressing the issue of all presumptive TB patients, while the current recommendation for TB-LAM is restricted to people living with HIV and largely with usually advanced HIV disease, right? So it's not being used currently for all TB because the test performance is not sufficient at this stage. So primarily the document focuses on molecular tests for TB in simple terms. It does include LF-LAM and monitoring that, but specifically within the spectrum of people living with HIV. So it is included, but not a key focus, to be honest.
Great. Thanks. Yeah. I think that's very important to highlight as we discuss the standards.
Yeah. I forgot you had asked me something about the turnaround time, right? So just to come there, because there's been a very debated topic when we were developing the standards, and maybe I can give some insight on that question, right? So the turnaround time, the challenge is that people think this can't be measured. We've tried to simplify it as far as possible so like people want a turnaround time from the patient, from the time the person walks into the door till he gets the result. And that for sure is extremely difficult. But at least from the time a sample is sent to a laboratory to that result being issued is one proxy of that we can start measuring immediately, right? And we propose that as a sort of an immediate measure, and countries could improve on that. And I think that can be done even without advanced analytical tools, right? So, but I think we need to start measuring turnaround time, even though it might be more basic in facilities, but a lab that delivers service must know its turnaround time, right? And that must be known. Yes, please go ahead. I think you're muted, sorry. Yeah.
Yeah, sorry. Yeah, thanks for already getting deep into the key standards that are within the guide itself. Maybe just before we jump also onto the other ones, I've seen also questions around specific questions around those benchmarks that are coming through, like instruments. One quick question that I have is, it seems I'm playing the devil's advocate here.
Right.
It seems many of these standards are assuming the diagnostics are already in country. We know that it's not always the case. Did you think of some regulatory aspect of it, of whether the diagnostics are already in country, or we are only assuming that all of the countries have accepted them?
Right. So we could only put 12 benchmarks, right? So we had to limit ourselves in what we could do. So we don't have one specifically on regulatory aspects, but one of the benchmarks talks of testing capacity.
Yeah.
Which really speaks to it's regulations is part of it, but if you have a country and your need is X 100 and you can only deliver 20, right? So we're measuring that, and that would be a sum total of regulation, purchasing power, all of that to deal with the problem. So it does include regulations indirectly. Yeah.
Okay. All right. Thanks for the clarification that it's embedded in one of those.
Yeah, it's indirect, but it is to some degree there. Yeah.
Great. Yeah. Now, digging deeper into the benchmarks, picking one question here from Anaya Shetty, who I think he or she is touching on instruments, and says, given all the challenges with instrument-based testing, what would be the role of okay, maybe I misinterpreted this, but it's very relevant. What would be the role of lateral flow rapid testing? I think it touches
right the LFLM question. Yeah. Yes. So I mean, unlike the privileges of the people living like the HIV community that has rapid tests that are cheap and accurate, with TB we've struggled to have a point of care test. So the LFLM, while it is recommended, it's not sensitive enough to be used in people without HIV. Having said that, there is third generation LFLM technologies that are emerging. We plan to review this evidence, expected to be reviewed in 2025, depending on the studies that are ongoing right now. And I don't want to sort of there's no guarantee, right, of whether they'll perform or not. But there is some optimism to say that these might not be as great as Ultra, for example, but would be able to provide point of care testing. However, the reality is that I don't think we'll be able to get away with not using molecular testing for TB. Because even these LFLM assays don't detect drug resistance. So there's always a need for some molecular tests as such. So we need to, I think in sum, we need to do the best we can with what we have, not wait, but also consider the future where we will have, better testing in time.
Great, thanks. The chat is buzzing and questions keep coming. Please let them keep coming. Dr. Nazil, you outlined, I think the benchmarks are really touching the whole cascade, as you have mentioned, I think from the demand aspect until when the results are actually used. But most of the time we look at the end. It's like in a football match, people think of goal scorers. That's why soccer strikers are always more popular. So as a result, many of the questions that are in the chat are actually about the use of the results, connectivity, reporting. So we'll go back again. You touched the issue of turnaround time. And one of the questions that has been asked is, what is the role of connectivity in here from your view? Yeah.
Right. So we see it's difficult to put a benchmark for connectivity because it serves multiple roles. So we see connectivity as part of the enablers to achieve access, but not a benchmark in itself.
Yeah.
Right. So we say you need to have a certain turnaround time. How do you achieve a fast turnaround time? You could cut your turnaround time by half by having a connectivity solution that sends the result, right? So it becomes a solution rather than the benchmark. The benchmark should still be that turnaround time we're trying to achieve. So undoubtedly, connectivity solutions and ML kind of solutions are definitely important enablers. But I also just would like to caution that if you don't have it or you can't afford it, doesn't mean you shouldn't meet the benchmark. We've got to wait till someone gives us a connectivity solution, solve the problem, right? There are even more basic ways to solve the problem. Connectivity is a quick way, but I don't think we should stop.
Yeah, I think that's an important one. Connectivity is one of those means to make sure that the results come faster. I remember some days when I used to work in Botswana, I think it's over a decade ago, there was already a system where
Yes.
all TB results would be notified directly from the lab. It was not connectivity, but it was a simple phone call, and somebody else from the clinic would actually go and pick the patient. It worked perfectly well. I'm hoping it's still happening. So you have just answered also the question from Lawrence Kachule, who is speaking about how does the standard link with connectivity solution? It's only a means. And again, on that one, there is the element of lab information management systems. And people in the chat are throwing in a few examples. Maybe you could speak to that element.
Yeah. So again, it's the same thing. I mean, the lab information system where I come from South Africa originally, right? You know, lab information is kind of a basic thing, right? If you have a lab, you have to have a lab information system. So I think irrespective of the standard, people should have a lab information system, right? That works and serves the purpose. But we also need to look at the reality. In some places, there isn't a lab information system, right? And there's a small lab somewhere in the corner. And what we've done in the benchmarks, and we have an Excel tool that's also available if people need it. We try to simplify that. Even if you use a paper-based system, you could still monitor turnaround time, and you as a person managing that service could still track and make sure things are appropriate, right? So, but irrespective, I think in my personal view, lab information systems that are sort of not, I think two things, they shouldn't be sort of stuck on just one technology or one disease. I think lab information system should be a portfolio that accepts multiple technologies and can monitor it. So whether it's a service, right? It needs to be lab. It's broader than that. Let me stop at that.
Thank you very much. I think one of the questions I asked from the audience is, I think the purpose of putting benchmarks is for us to be able to measure something and follow progress.
Yes.
From your review, do we as countries have a way of collecting this data?
So that is the underlying problem, right? And to be honest, we do a very bad job well, I think we try, right? We try, but the whole challenge that we found is that it was very difficult to quantify some basic things about where we are with TB and where we are with access, right? And different partners were doing different things, etc. And what we've done with this benchmark is try and standardize what the collection should be. We force ourselves to limit it to 12 for the diagnostic cascade, but we think these are sufficient to be able to give a very good picture and to track progress, right? So there is gaps in data collection. If you look at the 12 benchmarks, 4 of them are already being collected. 4 we believe are, it's technically there, but not being captured, right? We think that's an easy win. And the other 4 are like technically non-existent, right? So for example, how many districts use chest X-ray for TB screening?
Yeah.
It's no such measurement, right? But it's an important one, right? So that'll require new work. So we see it as 3 buckets. The one is done. The second is like where we need to do a little bit more and get it done. And if we can get 8 of them being measured and reported ASAP, that'll be fantastic. And then build something in the coming year for the last 4. Yeah.
Great. Thank you very much. Yeah, I think we still have a way to go. 4 out of those at least are being measured. I think it's a start somewhere. Now, I think I want to go back again to Dave. Thanks, Dave, for being very active also in the chat, who actually has highlighted more that data is heavily underreported. Even for those that we are saying we have. And we are saying, and I think what he's saying is, I think ultimately what we need is to identify cases, whether it's going to be molecular tests or microscopy.
Yes, so that's true. And I think, even in South Africa, we have all these data systems, they're still missing data. right? Where I come from. And what we try to also do here is that because we're trying to engage the lab and get lab data in addition to programmatic data. So if you look at the number tested, number positive on a laboratory, and you find an X value, 100, and then the notifications are reporting 50, right? It already tells you something, right? It might not be, there's obviously nuances between that, but we've tried to also look at that because we know there'll be under-reporting, and trying to collect it from different sources helps you to triangulate and get a better picture. I think we shouldn't be I mean, we need good quality data, undoubtedly. But, once we identify problems, we can zone in and start dealing with the issue.
Okay, great. Thanks a lot. I'd like to shift a gear a bit, and this question from Richard M. Is also actually a very important consideration. And Richard says he appreciates you for presenting this, Dr. Nazir, and we all do. How are you collaborating with industry to improve their instrumentation? And he gives some examples of latest computer hardware, issues of cybersecurity, ICT tools.
Right. Okay. So in terms of dealing with manufacturers, obviously with WHO, it's a little bit tricky for us to deal directly with manufacturers, but we do engage, we do advise, we do provide some direction to them. The most important mechanism for us to deal with that is through what we call target product profiles. And just for this group to be aware of, we are updating the target product profiles for diagnostic tests and screening tests, which should be out hopefully towards the end of this year. It's already out for public comment in terms of diagnostic tools, and I think it closes today. But essentially, those target product profiles really sort of map out the community view on what needs to be there, what are the parameters, what are the targets. But just also know that these target product profiles are really focused on near point of care and point of care technologies. So it's at a five-year landscape. And then in terms of specific things, if manufacturers have queries or uncertainty, they're most welcome to reach out to WHO. I mean, we're there to advocate for better public health, and therefore, if there are issues, we would engage for sure.
Great. Thank you for that explanation as well. I know we are moving towards the end of the session, but we still have some more questions that are coming in the chat. And as you have seen, many of them are speaking to the issue of, excuse me, issue of turnaround time. And it's really about taking the result to the recipient of care. I just want to also make sure that I acknowledge Patricia for having put the link to the guide for rapid molecular diagnostics for TB. Please visit the guide and get to know more around this. Maybe as we go, I think this question from Papi Njibu kind of summarizes, I think, that whole cascade where he or she says, what are the challenges that you are dealing with? Low rates of presumptive TB, the non-integration of TB screening points, low coverage of diagnostics, sample transport, and all these weaknesses. In other words, he or she is asking us to really summarize this session today. Maybe I could use that question to give you an opportunity to summarize what we are advocating for.
Thanks a lot. And I think a great question. So what we're advocating for is improving access to diagnostics across the care cascade. And when we think of access, we don't think of just access to an expert instrument. We think of patient access to health services. We think of access to diagnostic tools in terms of availability of them, the access to being able to be tested and get a result out. And that's really what we're talking about, the 4 steps of this cascade. And the 12 benchmarks really are country level benchmarks to see where we are and track over time that we can actually achieve, number one, improvement across all steps of the cascade, but ultimately make sure that all people that are notified with TB have at least been tested with a rapid, WHO recommended rapid diagnostic.
Thank you very much, Dr. Nazir. I don't want to spoil your very good summary. I will just summarize and say the goal, as Carmichael has said in the chat here, is to really improve access to tests. And when they are accessible, it's whether they are actually being used. So I think that's the key, most important message. And if we can use these benchmarks to measure where we are for reaching, I think these two aspects, we will be actually getting there. Colleagues, as usual, all good things come to an end. The hour is quite short when you are speaking about very important things. So we wish to continue this discussion in the WhatsApp groups as usual, and we will probably continue these discussions in other sessions. As you can see, there's so many questions that we have not been answered. But allow me to thank Dr. Nazir and the team at the GLI, ASLM, the TB CAPT for bringing us this session. And most importantly, all of you for coming through and sharing this discussion. And we wish to see you in the next session. Thank you very much and have a good afternoon. Again, good evening and maybe good morning to those that are still enjoying the early part of the day. Bye.